that's it. And we're recording. Perfect. So just a reminder, we have one more presentation coming up in June on the 18th, where Alexa and I will be doing a presentation, kind of a review. We've done this one before, but it's just a reminder of understanding your COPD, what that means to your lung mechanics. And so we like to do a review of that for you. So that'll be June 18th at 10 a.m. The sign up will be coming up in the next few days, so please feel free to sign up as soon as you can so you don't forget. We do take the summer off, so June or July and August, we do not do presentations because everybody wants to enjoy the nice weather, and so do we, and we understand that. And we will resume in September. So without further ado, I would love to introduce a colleague of Alexa's and myself. We've worked with Ayla for not many years. No, I'm kidding. We've worked with Ayla. We've been very lucky to work with Ayla for a few years. Ayla graduated from Thompson Rivers University in the respiratory therapy program in 2006. She has worked in critical care areas until recently, about 2020, where her passion for working with her patients had her transition into community care. And her focus and passion are palliative care and chronic disease management within the city of Kamloops. She still occasionally will go play in critical care at the local hospital here, but she really does enjoy advanced care planning, making sure that she avoids what she's seen, which is that disastrous effect of poor planning while working in the emergency departments and the intensive care. So her talk today is advanced care planning. Start asking the questions. And without further ado, I would love to hand over the screen to Ayla. And I think that's it. Thanks, Ayla.
Thanks, Lindsay, and thanks you guys for having me. Let me just share my presentation now. And if you could just confirm that you're seeing my advanced care planning presentation.
You just need to share it so we don't see the side. So however you did it while we were testing it.
Yeah, that's what I thought.
Go into slideshow.
Oh,
Yeah.
there it is. Good.
Perfect. That's perfect.
All right, great. So yeah, as Lindsay mentioned, I've worked many years in critical care, and my experiences in critical care have given me a special passion for advanced care planning, just because it's so much more important than people may realize. And it's so important to get it done early. And so here is my presentation on advanced care planning. So what is an advanced care plan? Pretty simply, it's a plan you make so that you can have your goals and wishes followed during your disease, but especially at the end of your life. And it's important to know that you can change your plan throughout your disease. In fact, we would expect that your goals and plans would change as your disease progresses. And the plan is important to make regardless of whether you're incapacitated at the end of life or not. I mean, all of our goals is that we would not be incapacitated at the end of life and we could make our own decisions till the end, but unfortunately, that doesn't always happen. So, and who should make an advanced care plan? Everybody. Even Lindsay, Alexa, and I should have an advanced care plan, but it should especially be made as soon as you're diagnosed with a life-limiting illness, and COPD and pulmonary fibrosis are both considered life-limiting illnesses. And my advice is to not wait for your physician or healthcare provider to initiate this planning conversation with you. After this presentation, hopefully you'll be equipped to start the planning process yourself and then include your physician once you're ready. So the steps. So the first thing I do with my clients in community is I start with a serious illness conversation, and it's a guided conversation that some of us are trained to have with you and your family members. And really the purpose of it is for us to understand your goals, your values, and your anxieties surrounding your disease, and especially the end of your life. And then there's a MOST form, and that stands for medical orders for scope of treatment. And we'll get into more detail about what that is. And then there's a few supporting documents that are important for you to prepare. So the serious illness conversation. There's 6 questions, and the first 3 are this. So number 1, what are your most important goals if your health situation worsens? And this question just really helps us as your healthcare providers and also your family to understand things that you'd like to see completed if it comes to a point in your disease where you're unable to get them done. Things you've planning to do but haven't got around to yet. And what are your biggest fears and worries about the future with your health? This helps us to understand what your personal fears and worries are and kind of explore how we might mitigate some of those fears and worries and help you to feel more confident as your disease progresses. Third is what gives you strength as you think about the future with your illness. This helps us to understand where you get your strength and what you rely on to cope with your illness. Helps us to know what's important to you in your personal life and helps us to continue to offer that support as your disease progresses. This one is very important for us to know. It says, what abilities are so critical to your life that you can't imagine living without them? So these are things that you need to think about. What really matters to you as a person? Would you, could you imagine yourself living, for example, without being able to speak, without being able to eat, without being able to leave a wheelchair or leave a bed? These are just basic abilities that some people haven't really thought too much about how critical they are to your personal quality of life. And this question just really helps us to explore what you value about your life. And number 5, if you become sicker, how much are you willing to go through for the possibility of gaining more time? And I always emphasize that it's gaining more time. It doesn't necessarily mean that this is going to be quality of life. It's just more hours or days on your life. And so what are you really willing to go through if it's only going to increase the length of your life, but not necessarily the quality of your life? And then most importantly for everybody is how much does your family know about your priorities and wishes? Once you've had this conversation, and it's scripted, I can show you where to find the questions online, and you can have a family meeting would be great to discuss these questions, and then also with your healthcare provider. But once you know the answers to these questions, it's really important that you let your family know, just so, as we'll get into it, they can accurately represent you. So after you've had this conversation and you've kind of got a good indication of what's important to you and what your priorities and wishes are, we move into a legal form called the MOST form. And that stands again for Medical Order for Scope of Treatment. And I'm going to show you what it looks like. You won't be able to read it, but you've probably, hopefully, seen this form, and hopefully your physician has filled it out for you. But this MOST form outlines the pathways you can take during your illness. And this is important. A lot of people don't realize this, but your MOST designation will, and it should, change as your disease progresses. And I'll explain why. It's filled out with your physician in harmony with your wishes, but also with a realistic view of your prognosis. So obviously, as your disease progresses, there will be some treatments that would not be appropriate for you anymore. So we'll get into the details of the MOST form. So first, we're going to look at this very first part of the form, excuse me, which really outlines what we're going to do if you show up to the hospital. So there's 2 approaches. Number 1 is the critical care approach. So this is, the C stands for critical care. So there's C2, 1, and 0. And so C2 is all critical care interventions. We will do everything within our reach to keep you alive. And I have a form here. And under critical care, there's a little bit of an explanation, and it says, the adult is expected to benefit from and is accepting of any medically appropriate investigations and interventions. So you'll notice that there's two folds to that. You would be expected to benefit from, that's what your physician decides, and you are accepting of any medically appropriate treatments, and that's what you are able to decide. C1, we would still give you critical care. You would still go to the intensive care unit, but we would not do CPR or defibrillation, give you those shocks. But we would put you on life support with that breathing tube called intubation, and then ventilation on the machine that would breathe for you. C0 is a critical interventions, but it excludes CPR, defibrillation, and intubation. So we wouldn't put you on the breathing machine, but it does include intensive care. So those are the three approaches that we can offer that are critical care. Next is a medical care approach. And as a disease progresses to the point where we can no longer cure the disease, we may choose to move into a medical approach to care. And so some people call the medical approach the beneficial approach. Basically, we're only going to give you any treatments that we feel would be beneficial to you. And again, there's 3 stages. So M3 is medical management, which is directed at curing or controlling symptoms of illness. So when we've reached a point in your illness where we can't improve the illness anymore, but we can improve the symptoms. So we would cure the symptom by getting rid of it, or we would control it with other different medications and just make it so you feel less of it. M2 is symptom control with transfer to hospital if you need it for symptom management, but we wouldn't actually do any diagnostics. We would treat you solely based on your symptoms. But you could still go to the hospital if you require it for things like hydration or antibiotic therapy, things like that. But we would not do diagnostics. And M1 is the last stage of medical care where we just manage your symptoms and we do not take you to the hospital, and your care would happen at home or hospice. And the focus on this level of medical care is really comfort. So that's the first part of that form. On the form also, there's some interventions that some people may accept or decline regardless of what their order for scope of treatment is. And that is in this portion of the form that you can't see, but I'll blow it up in the next slide. So specific interventions. So regardless of whether you're a critical care intervention or a medical care intervention, you are allowed to say yes or no to blood products, nutritional support, so that's a feeding tube, dialysis. If you have kidney disease, you can say yes or no to dialysis. And then this one is really important to people who have lung disease. You can say yes or no to non-invasive ventilation. And what that is it's kind of, it's a mask that we put over your mouth and nose, and it basically just supports your breathing with a machine. It tends to not be very comfortable if anybody's had a very bad flare-up and ended up in emergency on BiPAP. It's kind of an intervention that could maybe get you through a really bad flare-up, but it would definitely not be useful for any long-term support. And then we're also going to talk about this section right here, supporting documentation, and that goes in this part of the most form here, which blown up looks like this. So the one I really want to focus on in this presentation is the Section 9 representation agreement. So I'll just go through this. We've been talking about planning, but as an overview, as a review, there's 2 different types of planning that need to be completed. So estate planning, and that's for after your death, and that just very simply is a will. And that's something you can complete with a lawyer. You can purchase will kits. They're very, very simple. It's not something to put off. It's not overly complicated. But what we're focusing on today is personal planning, and this is for while you're alive. And there's two branches of this. The one we're focusing on today is health and personal, but there is also legal and financial. So you'll need to appoint someone as your enduring power of attorney to take care of legal and financial matters. And under your health and personal, you'll have to appoint a representative to represent you for all healthcare and personal matters. And they can be the same person, but it's still two different forms. So again, your essential planning documents are a representation agreement. This is the one that's going to give authority to your representative to represent you in healthcare matters. And then you need an enduring power of attorney. And this is the person who's going to represent you in financial matters. And then you also need a will. And this is for what happens after you pass away. The reason that we like to give everybody this presentation early is because you actually have to make these documents, and it should be obvious, but you need to be mentally capable and you need to be thinking clearly. The representative agreement and the enduring power of attorney agreement are both used while you're alive if you lose the ability to make your own decisions. So both of these documents really only come into effect if you can't make your own decisions. And a will, it's used after your death, and it will not affect your health care while you are alive. So first, the Representative 9 agreement. So it's a representation agreement, and it gives your representative the authority to make very significant medical decisions and other decisions for you, including decisions to refuse life-supporting treatment. They may make any decision for you that you can make for yourself while you're capable. But there are some exceptions, obviously. For example, they cannot request maid for you, and they cannot interfere with your religious practices. So some people ask what happens if you become incapable before you have a representative agreement, and that in that case, you would be represented by someone you know. A substitute decision maker will be appointed. So this list is the order in which people close to you are approached to be your representative, and the order cannot be changed. And it's important to know that this representative really can only represent you during your current health crisis. It's called a temporary substitute decision maker, and I think in BC it lasts 21 days. And so if you become incapacitated without a representation agreement, your spouse will be approached first, and then a child. The birth order doesn't matter, any child, then a parent, then a sibling, a grandparent, grandchild, anyone else related to you by birth or adoption, a close friend, or a person immediately related to you by marriage. So again, even if you want your spouse to be your representative, it's still important to fill out the Rep 9 agreement, just because, as I mentioned, this is a temporary representative. And the trouble with this would be if you don't regain your capacity after your illness. If you don't regain the ability to make your own decisions, this substitute decision maker has to be reappointed every few months, or once a month, and then it goes into a different representation agreement that has more restrictions on it, called the Rep 7 agreement. And we'll touch briefly on the Rep 7 agreement, but I don't want anybody to have to be represented by a temporary substitute decision maker or a representative 7 representative. So just briefly about Rep 7s, they can be made when you're possibly incapable. So Section 7 of the Act allows you to make a basic representation agreement that covers your routine daily living requirements. In a Section 7 agreement, you can authorize your representative to help you make decisions or to make decisions on your behalf involving your personal care and the routine management of your financial affairs, including paying your bills, receiving and depositing your pension and other income, and purchasing your food and accommodation. But really, this Rep 7 agreement is, I asked a social worker, well, that sounds fine. It's almost like a POA and a Rep 7 power of attorney and a Rep 9 in one. What's the problem with that? And the problem is that you can sign this while you're possibly incapable, just because we need someone to represent you. And because of that, there's going to be restrictions on them. I won't get into the restrictions, but they're basically not going to be able to make any major decisions for you or make any major financial or legal moves on your behalf under a Rep 7 agreement or on a temporary substitute decision maker agreement. So we really want to get that Rep 9 agreement signed. And then an enduring power of attorney, just briefly, because it's not to do with anything healthcare wise, but it's a very important document to have completed. And I think a common misconception is that you need to have your will and your enduring power of attorney made at the same time. And that's actually not true. You can appoint an enduring power of attorney without a will. I mean, obviously, you need to get your will done as well, but they don't need to be done together, because I find people, they view the will as a very big deal, and it kind of puts off appointing an enduring power of attorney. But if you become incapable and you don't have a power of attorney, your loved ones, excuse me, will have a very hard time doing anything in your behalf. For example, I have a client who's been in hospital for months, and her family is unable to end her care home lease. So she's paying thousands of dollars a month because they don't have the legal ability to cancel her lease in her care home. Simple things that you don't think of. Your power of attorney is the one who can cancel subscriptions and things like that. Just to save you money if you're not using your subscriptions, but also they can pay your bills. They can, yeah, it's a really important document for legal and financial matters, and those things cannot be done under a Rep 7 agreement as well. So basically, they are able to do what you could do if you were capable. And so because of that, it does require a lawyer. And so a lawyer just you just need to notarize that you've appointed this person to be your power of attorney. And all this is well and good, but how do you actually do it? So there's a really great website called NIDIS. And let me just see if I can open it here. I think I can, but I have to end my presentation briefly. So I'll share this link, but this is a website that helps with advanced care planning here in BC. And so you click on forms, you click on representative agreement forms, you click on the Rep 9 form, and then right here is all the extra information that I don't have time to cover with you guys today, but frequently asked questions and informations. And then there's just a very basic representation agreement form right here. And so it looks big and long, but it's really just you, your representative, and then 2 witnesses to sign that you are of sound mind when you're appointing this representative. And it's just a very simple way to make sure that your wishes are followed during your disease if you for some reason become incapacitated. The website also does offer help on other forms, like your enduring power of attorney and your will, but mostly information, because these forms do require a lawyer, so you can't fill them out. You can fill them out on your own, but you need to have them a lawyer involved. Where I work in interior health also has this great advanced care planning guide that I can also share the link to. It's a very long document, but it basically goes over every single thing that we've talked about today, but in much greater detail. I think there's 52 pages, and it really clearly can help you understand the benefits of a representative agreement. So I will share those. And just as we're getting towards the end of my presentation, I wanted to talk a little bit about, oops, I better get to the end of my slides. Sorry about that. Just, I wanted to talk a bit about the palliative care to approach. A palliative approach to care, sorry about that. This is something I feel pretty passionate about, and palliative care is such an important goal to care, and I feel like a lot of people misunderstand it. So a common misunderstanding that I face in my daily practice is that people feel that palliative care only happens in the last days to hours of life, and that is not correct. Palliative care is an approach to care where the goal is to minimize suffering. So the goal is quality of life over length of life. And that being said, though, a palliative care approach does not decrease length of life. In fact, in studies, it's been shown that if we initiate palliative care early, it actually can increase length of life. So for example, a person who knows that their disease cannot be cured may not want to undergo uncomfortable procedures that won't improve the quality of life. He may say to his physician, I would like a palliative care approach with the goal to live comfortably as long as possible, which I feel like that's all our goals. We want to live comfortably as long as possible, but sometimes if you get yourself into the medical system, you can be undergoing a lot of unnecessary procedures that won't improve your quality of life, and the palliative care approach kind of prevents that from happening. And in Canada, there's a special set of benefits. They're called palliative care benefits. And so in the estimated last 6 months of life, a person qualifies for palliative care benefits. So these benefits, they cover the extra costs associated with increased health care towards the end of life. A person may only receive medical care. So remember those most levels that we spoke about. You have to be an M1, 2, or 3 to receive palliative care benefits. And then there's this caveat here, unless a critical care procedure will relieve suffering. Because remember, our goal with a palliative care approach is to relieve suffering. So you can still have critical care procedures if the goal of those procedures is to relieve suffering. And interestingly, a person who has palliative benefits and then lives longer than 6 months is just reevaluated yearly by their physician to determine if they still qualify. So if someone mentions palliative care to you and they kind of are trying to improve your symptoms, don't get worried. Palliative care does not mean that you are going to pass away immediately. What palliative care means is that you have a disease that we can't cure, and so we would like to switch to controlling the symptoms. And people can have a palliative care approach for years, and it really improves the quality, a person's quality of life. So in conclusion, you need to really for me, the very important one is this Rep 9 agreement. You don't need a lawyer. The basic form is free. And then you can appoint a person you trust to make your healthcare decisions if you need them to do so. get that enduring power of attorney finished. And this is for not only financial decisions, but also for financial care while you're possibly unable to make these decisions yourself. And then do finally get a will for after your death. And that is the end of my presentation. If anybody has questions.
Ayla, thank you so much. I do have a quick question before we jump in. All of the forms, the Ret 9, is that Canada-wide or just within BC?
It is within BC.
Okay.
However, every province will have their own version of it.
Okay.
It's actually the same with the most. I know in Alberta, C stands for comfort, and so it's
Okay.
actually opposite. So depending on where you're living, they will always have the most form, but the goals might be different, and there will always be a representation agreement form.
Okay, just we have some people that usually attend from across Canada, so I just wanted to make that clear for them. That was my only question. We didn't have any questions in the chat box because I think everybody was just so glued to your talk. So if anybody has any, yeah, I'm getting a nod. If anyone has any questions, please feel free to unmute yourself, say your name, and then ask your question. We've got Ayla for 28 more minutes, and she is a wealth of information.
There was one comment in the chat box, Lindsay, regarding handouts. I semi-answered it, but because Ayla, you touched on a lot of handouts.
I did.
I think like the best, what I mentioned to Kay who chatted, put in the chat, this video is being recorded. So if there's a certain part that you want to go back, a lot of these handouts are available on the web. So I put the link to our webinar recording, so you can go on there and if you want to watch the video again to learn more information, or because there's quite a few documents, and depending on what documents you want, you can go on the web, I believe, to get any of those.
Okay.
Yeah, and I can just
put the links in the chat.
Paste my links in the chat as well.
Yeah, that'd be lovely. Just that nidus.ca and then the interior health booklet. Yes, that'd be lovely. While you're doing that, Ayla, I'm going to make you multitask. Karen just put a question in the box asking, what is and when should an advanced care directive be made?
So an advanced care, sorry, I'm having trouble opening the meeting for some strange reason. Oh, there it is.
Oh, okay.
Okay, advanced care plan. So an advanced care plan is, it's an important document as well. Let me just, let me scroll back up to that most form.
Yeah, there's no rush.
It's under your supporting documentation in, let me show you here. This here. So on your most form, part 3 is supporting documentation.
Oh, and so, oh, there we go. Okay.
Oh, sorry. Is it
it was a little buzzy, but it's cleared up now. It's perfect.
Okay. Sorry about that.
Yeah.
So remember that big most form that we had here, supporting documentation, part 3. So an advanced directive, for example, if you have an advanced directive where you don't want to receive blood products, or you have some other, you're a diabetic or something like that, you would click advanced directive here. And so an advanced directive really is just a way to quickly tell the healthcare workers important medical information about you. Your Section 9 representative should also know about any advanced care plans. And what was I just going to show you here? Oh yeah, so if I, take you to NIDUS again. And we go to your Rep 9 form. Actually, it's already open. There is a section in this form where you would write down your wishes. So right here, instructions and wishes. My representative and alternative knows my instructions, wishes, values, and beliefs, and I trust them. when acting as my representative to apply these in the appropriate circumstances. And then there's a big space here for you to write anything about your advance directive as well in here. But great question. An advance directive should be written alongside these documents. Now let me unshare my screen if I can.
So keep your screen up for a second, Ayla.
Oh.
Because there's a question in the chat. Yeah, if you go back to your Internet Explorer browser, you just open up the My Voice Advanced Planning Guide.
Yeah.
And can you throw that?
Put it in the chat already.
Oh, you did? Okay.
Okay.
I replied to Alan.
Oh, perfect.
Can you see it?
Oh, okay. Thank you, Lex.
The next question was, Ayla, could you explain the two procedures, intubation and ventilation?
Yes, I certainly can. So intubation, we would intubate a person when they can no longer breathe for themselves. And so what it is it's a long, flexible plastic tube that we put through your mouth, and it sits in your trachea, about 5 centimeters above where your trachea splits into two. And it is how we deliver each breath by the ventilator, which ventilation is how the breathing machine would breathe for you. So we call it a ventilator because it ventilates you, as confusing as that is. So it would give you a certain amount of breaths per minute and a certain volume with each breath. So it's basically taking over what you and I do naturally all day, just breathe. In general, people with advanced lung disease do not do well with intubation and ventilation, and that's because your body is better at compensating for your disease than a machine is. And so we would try pretty hard, if you have advanced lung disease, to not intubate and ventilate you, and that's where that BiPAP would come into play. If your physician felt that you would benefit from non-invasive ventilation, we would try that first, just because your own lungs are much better at breathing for you than we are.
Comment on that answer?
Would you turn up your microphone or just speak a little bit closer? I think I heard somebody speaking.
Yes, I'm sorry.
That's all right.
I just wondered, with COPD and the lungs themselves being in such brittle condition, it would be naturally unadvisable to pump air into the lungs, would it not?
Yeah, and so intubation and ventilation are actually life-saving procedures. They would not be done unless they were necessary to keep you alive. However, in advanced lung disease and in COPD, many people may not survive the procedure, which is why advanced care planning is so important. Because if you are at a stage where you have advanced lung disease, what I try and encourage people to do is to really review their MOST form with their physicians, because the physicians have a lot of say in what they feel would be beneficial for you. Because remember that on this form, yeah, you can't see it because I have it blurred, but sorry, it says that we have to decide whether you're expected to benefit from the procedure we're offering. And so with advanced lung disease, it's pretty common that intubation and ventilation are not beneficial. And that's something you need to discuss with your physician, whether they feel it would be beneficial for you.
Thank you.
Perfect. Ayla, I have another question for you regarding palliative care benefits.
Yeah.
Does this include prescriptions that help with pain or depression, especially if they have been on them for years, or does it just include new prescriptions?
Good question. If you are entering the last 6 months of your life, I would expect that your pain management medications would be changed. And if they're not changed, you would receive adjunct therapy. Adjunct therapy just means therapy that increases the efficiency of the medication you're already on, and that would be covered. I do believe that under palliative care benefits, any medication that you have been prescribed for symptom management would be covered. So it may not include things that are not for symptoms, but it would include any pain medication for sure, even if you've been on it.
And I think maybe that could be answered even more in depth by your primary care provider. So your physician or nurse practitioner might have more information about that as well. Anything to add to that, Ayla? Or?
Nope. There is a list of medications that are covered under palliative care benefits, but palliative care benefits are very wonderful. It's recognized that every intervention that's prescribed is going to improve your quality of life, and so in general, they're very generous with what they'll cover.
That's lovely. That's it for questions in the chat box, unless Alexa, you've got any on your end?
No, I
And
think we've answered all those. Is there any other questions on the line?
May I be given the opportunity just to address an issue relating to the MOST document? Just by way of explanation, I was advised of this through the Better Breathers group, which is conducted through the regional interior health here in Trail, the West Kootenay. And I then actually addressed my doctor directly when I became aware of the document. And he said, oh, right. Well, yeah, we got to complete that. And so I just want people to be aware. This is, in my opinion, probably the most important document to put on your medical records. And what my doctor did, he's a great guy, but he just, without consulting me, he ticked C2, critical care interventions. And, I'm pushing 80. So, I thought, well, I don't know. I guess that seems right. And then he said, blood products, yes. Non-invasive, the part 2 he completed, along with nutritional support, dialysis. But where it says other, he just wrote in there, does not want to be maintained in a vegetative state. He just put those documents in. Then, if you go to part 3, it is really, because it makes reference to the representation agreement, and you have to tick that box. And he didn't ask me whether I had or I didn't have a representation agreement, which now I have, but then I didn't have. But then if you go to part 4, you have to tick that you're a capable adult, i.e. you have your cognitive abilities and legal capacity. And then you have to put in your representative, who would be the person you've appointed, I would think, under your section 9. So if those things are on there, this is the document that the medical authorities will be looking at. All the rest, quite frankly, in the heat of the moment, they're not going to sit there and start reading section 9 agreement. So I just caution you there. I also caution you in this regard. What happened when my doctor finally got over? I said, could I have a copy of it? And he said, sure. And then I said, well, you haven't signed it, which is kind of important. You'll see the doctor's supposed to sign the summary of the order. But what is, it's notable, it could be a physician or a nurse practitioner.
Yes.
And as a final consideration, I actually, because of the therapist or the sponsors and supports our group, she's able to access our medical records directly. And I asked her, did my MOST document get on my medical records? She said, no, it's not here. So I actually had to phone the medical office and say, would you please ensure this placed on my record? And I mean, those are just practical matters, but people, you know, when you see the process, and Ayla, you've done a wonderful job of focusing in on this, like these issues. But when you look at the documents that you have to read for the advanced care planning and the summary to process a most document, let me tell you, your eyes will glaze over because it's really quite intimidating and very difficult to follow because it is a fairly complex. Well, it is. It's an important decision to make. But more than anything, I would ask that, uh, you know,
Yeah.
people understand and ask for a copy of. And another thing that I hadn't thought of, which Ayla mentioned, of course, it changes because if you become, at an advanced state of care that you don't wish, you would change from C2 to M3 perhaps, and then you would need another form. And it's all having the cognitive ability and knowledge to do these things. It's quite complex. So I would just have those thoughts for anybody that is dealing with this dog. I'm not trying to intimidate anybody, but because in many ways, it's just trying to make the best informed decision you have or can make,
Yes.
and then ensuring that it gets out to the people, that not only the medical profession or the medical care system, but also to your next of kin or the people that are going to care for you. So that's my comment on the most document.
Yeah,
I also
right.
would say on the dairy power of attorney, it's not correct that you need to get a lawyer or a notary will do them. It is true that if they can be completed without either one of those people, but to have it enforceable for the purpose of, it's a very powerful document. You're giving that person the ability to deal with your legal affairs, including transfer of any legal any real property, your home, or and the people, that's why it's important to actually speak to a lawyer in order to have you so you clearly understand what you're doing. But technically speaking, you can get one done, and then
Yes, you can. You just need a
have it
legal
notarized
representative.
later.
Yeah, you're right, Ken, for sure. Thank
Yeah.
you for your information. I think that's key.
You know,
Just to summarize that, it's important to be an advocate for yourself, make sure your documents are filled out appropriately, and make sure that they're on record, like Ken noted. So really important to follow up. Physicians, primary caregivers are very, very busy. I hate to cut you off. I just have a few more questions that I wanted
Sure.
to address
Excuse
before
me,
we
not at
run
all.
out of time.
Thank you
Cynthia,
very much.
hand up. Cynthia, would you unmute yourself and ask your question?
Thank you. I'm unmuted, and thank you for the presentation. What caught my attention was needing a lawyer for a power of attorney, and I went back and I was wondering, is there a termination date? I mean, I realized in 1996 I had a will with a lawyer and an enduring power of attorney, and all that legally done, and that doesn't expire. That my daughter and secondarily my brother would take over those affairs, and they're both still living, so that would still be my case. That does that expire for any reason?
I am not actually an expert on the legal portion of it, but I don't believe that they would expire.
Okay. I mean,
I think
Oh,
sorry, I was just going to say, I agree with Ayla. I believe unless you specify that you want to make changes to it, whatever legal document you have will be standing until you choose to elect somebody different. And then I believe that requires a new document to be created to then take precedent over the previous one. But I think if you still have, I mean, I'm a power of attorney for my parents and their medical decision maker, and that was done 15 years ago, and they haven't changed it unless they just haven't told me. But yes, I agree.
Okay, that's good to know. Thank you.
Thank you for waiting. I appreciate your patience with that. Is there any other questions? We've got a few minutes left. I know it was a lot of information. Ayla did put the links in the chat box. We will have this posted, but there's a lot of resources for sure that you can investigate these forms, fill them out, take them, do as much work as you can before you go to your healthcare provider, because then you're optimizing as much time as possible. We know they're busy.
I'd just say one thing, this presentation was so great, Ayla. I love you presenting on this. Just with experience working in acute care, you go and do these documents, and it's important to make sure that if there's something that you have a very strong desire or you don't want done, to have that communication with those people who are going to be representing you or being your voice. A lot of the times we see patients fill out these forms, but they may not have communicated that with their families or their loved ones or those people that will be their voice. And there'll be those cases where, you're traveling and you may not be in that health authority where you filled out your most, and it's not as quick to grab and pull up this information, but they do make these phone calls really quickly. So if you know that there's something that you do not want done, you do not want to be intubated, you do not want CPR, make sure you have those conversations with the people that will be representing you if you're unable to. So I think that's my one kind of takeaway from this, is just to make sure that we're giving you the care that you're wanting or not wanting.
Oh, sorry. Oh, no, I was just going to mention a lot of times people, they read about the serious illness conversation and they think, oh, that's an excellent conversation, we should do that. And then they skip right to the representation agreement and don't have the conversation. But it's a really difficult thing for a family member to represent you if you have not made it crystal clear what you will and will not accept. And it's good to just have that conversation, what your goals are, what your values are, what you don't want to live through, what you don't want done to you in the hospital, and make sure they know that. Yeah.
It makes it easier for the family too, that they're giving you what you want, and it allows them to make sure that they know that they're representing you and your wishes. Makes it easier.
I think one of the biggest things we see in critical care, especially as respiratory therapists, is that if not all family members are aware of your wishes, they may feel like they're not doing what they should for you if they don't know what your wishes are. So yes, your representatives definitely 100% should know what your wishes are, but also disseminate that information. Tell your loved ones that if the time comes, these are your wishes, so that they feel like they're doing right by you.
And just for Ken's point, he mentioned that his doctor just clicked C2 and then was good with that. And that's actually super common. If you don't have this conversation with your physician, he is most likely going to just click C2. And so it's good for you to advocate for yourself and say, I don't want critical care interventions. I want to focus on quality of life versus length of life, things like that.
Hey, I think we have time for one last question, and Jacqueline Turvey, somebody that we've seen and we know, has her hand up. So I think she has a question, and balloons in the background. For some reason, it's a party.
This is from our harmonica class. Sorry, guys. I'm just going to keep it up because I have my camera on real brief. I think one of the things that I wanted to add too was it's great to let the people know that are making the decisions, but also share with your family and friends who are not your decision makers, so that the person that is making the decisions has support around them as well. Thank you.
Great. Yeah, for sure. All right. It's a few minutes before the hour. If anybody has any burning questions that they'd like to ask in these last few minutes, please feel free. If not, I know Ayla is a very busy gal and has things on her list. So going once.
Could I just ask one question? With
Yes,
the
and then Jacqueline has
NIDIS
it.
document, the Section 9 NIDIS document, do you have to print that out and complete it by printing in the details? Or you can't do it, produce it on a computer and fill it in on your computer? I just wondered that.
It's not, no, Ken, it's
No.
not a
I
fillable
probably couldn't
document.
anyway, but yeah.
Yeah, you have to print it out and fill it
Okay.
out. It's not a fillable
wondered.
PDF. Good question.
Thank you.
Yeah. Yeah. And Jacqueline, I think I saw your hand up again, or
Sorry.
no, it's okay. It's a good question. Oh, no, she put her hand down. Okay. Thank you, everybody. This is a big topic and it's an important one. So we very much appreciate your time and your attendance. And yet again, this will be up on the YouTube channel in the next couple of days. So take a look for it there. And then a reminder, Alexa and I will be doing a review of understanding your COPD on June 18th at 10 a.m. So we will all see you then. Have a good month. Thank you so much, everyone.
Thank you.